we have Professor Prabhat, Professor of Global Health, University of Toronto. We have Dr. Lynda Stuart, Executive Director of the Institute for Protein Design, University of Washington School of Medicine, and Dr. David Agus, who is a founding director and CEO of the Lawrence J. Ellison Institute for Transformative Medicine. I think our session comes naturally after what we've just heard, and we really would like to refine further always on approach and reflect on its application to various components of pandemic preparedness, including, I think, hugely importantly, digital health infrastructure that is not equal everywhere, and vaccination that we've already heard a lot about. So we will discuss how Always On aligns with other global and national health priorities, and what are, importantly, potential setbacks that we need to be prepared, blockers, difficulties, and how we could overcome those to implement what we think is important, and not in 5 years, not in 10 years, but soon. So my first opening question to the first panelist, to Prabhat, is there are initiatives to improve routine healthcare, such as universal health coverage and pandemic preparedness, but they normally tackled separately. You have told us that conceptually, you know how the two could be shared, could become one. I think that's hugely important. Could you tell us more about this?
Thank you very much, Anna. So I suppose we can think about universal health coverage as routine and pandemic preparedness as the dramatic. And I hope I can convince you that the routine is as important as the dramatic. And I'm going to do so by giving you some numbers. So I apologize, I'm an epidemiologist, so I do give numbers. The criticism of epidemiologists is that we're number crunchers like accountants. That's not fair. Accountants have more personality. But let's start with the 20th century as a whole. Well, in the 20th century, approximately 100 million died from pandemic flu. I mean, the numbers vary from 60 to 100 million, but approximately 100 million. 200 million from man-made and basically men-led natural disasters, wars, or famines. But 2 billion children died from routine infections, now much of which is avertable through vaccines. Go forward more immediately, Ebola killed throughout its course and was very devastating in some countries, but it killed 10,000 people. That's the number of children that die from malaria every week. And if you look at particularly the COVID numbers, COVID killed about, at its peak, 140,000 a week over about 2.5 years. Most of those were above age 70. Today, we've got killers in middle age. For example, vascular disease kills about 120,000 people just in middle age. Malaria and tuberculosis kill about 50,000 people a week. So if we think about what are priorities, then the business of thinking, well, you either have routine universal health coverage or pandemic response is a false dichotomy. You have to think about interventions that address both. That's one point. The second is, as Tony Blair eloquently reminded us, politicians have attention deficit disorder, and they move quickly on from one concern to the next. And it is worth reminding that if the concern is not to have the catastrophic body counts that Rasmus scared us all with, it's important to know what went on with the past pandemic, or the COVID pandemic, which was very much the excess deaths were in those that had existing disease, very much in those that were with existing chronic diseases and in the elderly. So as a matter of building resilience, then you have to think about building resilience in health systems and individuals. there's been some elegant work that has outlined that the fully vaccinated child, and hats off to Seth Berkley and the folks at Gavi that have really advocated this idea, leave no child unvaccinated, but the fully vaccinated child is quite resilient now to a range of infections. I believe with more randomized evidence, some of which will be discussed this afternoon, we could make the case that the fully vaccinated adult will also be resilient. And this is a way for health systems that are somewhat weak to think about what can you do to narrow the gaps. The US is an example. I believe in the US, which has, as you saw, much higher death rates from COVID than in Canada and the UK, a strategy that would push vaccination, including routine flu vaccination, might be one of the best ways to mitigate the fact that there's very high levels of obesity and diabetes and lack of healthcare system access. So these are complementary strategies. My third point is really to think about what's relevant for various countries. In high-income countries, it's unambiguous that an expanded vaccination program for adults would be hugely cost beneficial. Just take flu, for example. In Canada, which has a national vaccination program for flu, only 40% of adults get vaccinated, and above 65, where it should be 100%, only 70% do. And that's in a well-functioning, reasonably well-functioning country. And we know the benefits from routine flu vaccinations would include decreased absenteeism, fewer sick days, less time off work, as well as reducing the inappropriate use of antimicrobials, so you actually decrease antimicrobial resistance through vaccinations. Now that's a high-income strategy, and we have to be careful that that shouldn't be a one-fit-all strategy if we think about a always-on approach. In the case of Africa, the priorities would be very different, I believe, and Dr. Tagenge, I think, mentioned upon some of these. So consider a place where we've done a lot of work, which is Sierra Leone, which has shown already that malaria is a leading cause of death, not just of children, but also of adults. And one of the key pillars for an always-on strategy in a place like malaria would be to have introduce adult vaccination as a strategy. And I'm delighted that just yesterday the Oxford vaccine, the R21 Matrix M vaccine, got licensed in Ghana for use in children. It's a great name, by the way, R21 Matrix M. I can imagine Keanu Reeves, doing advertisement for the vaccines. Extending those vaccines and that entire vaccines to the life course is probably one of the key areas of global health attention that we just have not taken seriously. In countries, there would be significant demand for customized sets of vaccines that would address the sets of priorities. So you can think about the components of an always-on somewhat differing by country, not just being focused on pandemic respiratory viruses. So I think putting these together, it suggests that we should avoid false dichotomies, and we should really focus on what is a country-specific strategy that would build resilience. And we know, we have so much evidence that routine vaccines would build resilience.
Thank you so much. We're now going to Lynda, and I think the start question for you is, from your experiences of vaccine R&D, how can our always-on approach be aligned with developing sustainable manufacturing capacities worldwide?
So I just wanted to follow up a little bit also on your point around health. And I think what I love about the always-on concept is that we really need to shift the dialogue, I think, in healthcare away from disease treatment to actually really focusing on keeping people healthy. And so, beyond the always-on concept, but just if that's your premise of what your health system is for, then always-on makes an awful lot of sense. And I think one of the things as we look at the R&D pipeline, which is really important to be able to sustain anything like this, is really what are the interventions that we can either exist or we can develop that actually keep people healthy and stop people from getting sick. So I always love the idea of the once yearly lipid injections, so you don't have to take your Lipitor. You know, these are in addition to, you know, the vaccines for infectious disease. So I think really having a health focus to our R&D pipeline makes a lot of sense. So for me, the always-on approach it really needs to begin at the very beginning of having not just manufacturing capacity, which is actually very, very far down the line of what you actually need. You need an always-on approach to research, and really need to strengthen, I think, the research capacity globally. And, you know, I think during the pandemic, we saw some real pockets of brilliance that came out of some of the research teams, particularly in Africa. And I think we need to keep and maintain and grow and develop that capacity, because if you have the research capacity on the ground, you also have the capacity to generate IP on the ground and to have that IP co-owned, co-developed by the Global South. And that gives us sort of, that empowers a whole system. It fuels the system in a very different way than, you know, this idea of trying to tech transfer things in an IP. You know, if you really have the research capacity, you can develop the IP and drive a whole ecosystem. And then I think a lot of this is also really possible now because we've seen some really great technologies. You know, I love technology. I'm always about wherever the great new technology is. But I think the technology is there, and I think what we heard in the very first panel today is it's really that we don't have the political will to get some of this stuff done. And I think technologies such as mRNA is extraordinarily powerful. I feel very strongly that mRNA is actually going to be a democratized thing pretty soon. You know, every company is going to have their mRNA, you know, and everybody, you know, it's just a very powerful workhorse tool, commodity that will enable a lot of this infrastructure. And with that comes a real transformation in manufacturing because it's easy. It's relatively easy to do tech transfer. And I think there are other sort of research tools, technology tools, which really are rooted in computational and not having to rely so much on wet lab R&D that will, I think, also facilitate a sort of different way of thinking. But with regard to manufacturing, I do caution that I don't necessarily think we need to make sure that that the capacity is full, it's being used. You know, empty, idle capacity is just going to cost the world a lot of money. And that's why I think really building the pipeline that sustains that capacity is important. I think we need to be careful as we try and fix the pandemic thing. We don't break really important structures like Gavi and the EPI vaccine schedule. We should need to understand that if there is a limited financial capacity, how do we build the commercial models that actually allow that, both of those to exist? I don't think there's an either or, but I'm not a money person. So somebody out there who understands money needs to work out how we do that. And I think the way to start is to really start with the places where there's obvious benefits. So the adolescents, pregnant women, where there's adult vaccination programs, where the cost benefit is clear to people. And I think there's going to need to be a lot of market shaping. But I do think if we have a really strong pipeline of products that really focus on health, I think this is an entirely doable thing. And that's really kind of, you know, why I'm quite optimistic about the whole ecosystem.
Thank you. Thank you so much. So we're coming now to David, who said not to have too high expectations. Don't
worry, I won't fulfill them.
We have huge expectations. And the question here to start with is, what potential do you see in applying always-on approach to digital health infrastructure? And what do you think we need to put in place now to achieve this speedily?
You know, I mean, Rasmus gave this remarkable presentation to an audience of converted, right? This was the greatest argument for an always-on approach, yet the people who just heard it, we already knew that, and we did, but the rest of the world doesn't know it. So figuring out a way to, first of all, dynamically show things like that on a daily basis, what's going on, to normalize the idea that we have to be ready or else, I think is critical. At the same time, we need leadership in this space. Yeah, we could do manufacturing all over the place, and we should be doing manufacturing. But if you look at what is an always-on program, there are multiple different technologies for different vaccines, for different preventive therapeutics, whether it be for lowering PCSK9 for 6 months or whatever it is. Those all require different manufacturing in different factories. Those are remarkably inefficient. At some point, we're going to have to normalize on individual ways and say, this is what we're going to stick to. But the root to all of it is building that digital infrastructure. You can imagine that you have a large country or a small country, and if every person is pre-registered, you have the ability of sending a message to she or he that they need to be proactive and that this needs to be done. We don't have such a capability in the world. It's all done by, a pull. We hope they come in rather than pushing something to them and making them come in. When we talk about supply chain management, when we talk about getting the personnel required to do all of this, managing all of this, it's a digital infrastructure. The digital infrastructure to do this did not exist a decade ago. We could not build sovereign cloud-based facilities for a reasonable cost really until this last year or two. So all of a sudden, here's a remarkable opportunity for the globe to have either a sovereign Stripe or a sovereign-based cloud facility in every country in the world where we can have this pre-registration, we can have the ability of managing, and that management can lead to being able to cross borders, being able to do commerce. In the end, it could be the foundation for many other things within a country, but it has to be begun, and we have to normalize this idea. There's this notion out there, if I said, Lynda, send me all your credit card records, send me all your bank statements, and I'll consider giving you a home loan, you do it and you don't even know who I am. If I say to a country, I want to take your health records and your health information in a privacy-protected way, keep it secure in the cloud, so we can enable you to be told that you need a potential health intervention and enable you to go someplace without fear that you could bring something that you're vaccinated to that country. You say, no freaking way, it's my health records. I care about my privacy. We now have the ability of privacy protecting that data. And so technology has changed, and we have to normalize that idea. Once we do that, things will change. In the middle of the pandemic, we approved vaccines for people in the United States. We did not approve it for pregnant women or breastfeeding women. We helped put together a program called vSafe, where we were able to communicate with every person who got a vaccine and got their side effects on a regular basis and question them, push questions to them, get information back. And very quickly, we had tens of millions of responses. Many of them were hero healthcare women who said, screw that, it's not approved, and I'm still getting it. If I'm pregnant, I'm still going to get that because I want to protect myself and my developing child. Or they didn't know they were pregnant. And all of a sudden, within a month or two, we had enough data that the FDA used that real-world evidence to approve it for those people under emergency use authorization. So the notion that we can actually have a system and collect data in real time around individual populations is here today. We just have to use it.
Thank you. I think that was really tour de force. Thank you. I think we can try some questions that are coming on a working iPad. Thank you. Came to me. And the question I have here is, there are 1.3 billion people with disabilities worldwide, and this population experiences 3 times to 28 times higher mortality rate during the pandemic. What does a disability-inclusive, always-on approach look like? It comes from Sarah and virtual. Who would like to tackle this? I think hugely important question.
The beauty of a digital infrastructure is you can make a hierarchy for need. And I think that's critically important in today's world. We are not all equal. If you are 90 years old, you are much higher risk of complications of something than if you are 20 years old. And when you have limited infrastructure, which we do many times in things when they're initially rolled out, putting it to the hierarchy of need makes some sense. And certainly disability is a need, and those people are higher risk for certain morbidities and may benefit more from an intervention than somebody else who can wait till there's more in the pipeline. So I do think we need to start to establish what are risk factors and have that so when we do roll out something, we can give it to the most people that need first and then to the others.
Thank you. We've got a really interesting question, and I think it is for Lynda. mRNA vaccines have very high cold chain demands infrastructure for which is extremely expensive. How can vaccine development balance efficacy with logistics? And that comes from a public health physician, I think, online.
Yeah, I think...
And if you could address world peace after that also.
Go for it.
So I think mRNA vaccines do have a cold chain requirement. Actually, I think there is actual technological advances, and they will improve over time. I don't think that's going to be in our future world is going to be a major limitation. They're still going to require some cold chain. But I think maybe to the question really is around, if we are inventing new vaccines, how do we make them deliverable and be able to reach the last mile? And a lot of that is in technology advances that are not just around the platform, but also how we design vaccines. We've seen, for instance, with COVID, there was structure-based design that really stabilized the actual immunogen, which actually made it possible to actually be, in a lot of cases, it made the vaccines more thermostable. So there's a lot of R&D we can do if we are bearing in mind that that's what we need to get to at the end. And I think that's now very first of mind for people when they're designing new vaccines now.
Great.
Can I ask you a question real quick along those same lines? If you were the always-on czar, would you...
Okay.
She just accepted the role.
You got to ask what's his salary first, then come on.
No, I'm not worried.
So, would you mandate one platform, or would you let it be a free-for-all like it is now?
I don't think one platform will do everything. I think there are things that, glycoproteins, carbohydrate vaccines, just you can't do on an mRNA. But mRNA essentially makes protein, so mRNA and protein are very similar, and most things that you can do on protein, you can do on mRNA. So I think consolidating around a couple makes sense, but I don't think a free-for-all is going to be problematic for tech transfer. Every time you tech transfer a different process, it's very difficult. So,
great.
Okay.
Do I get the job?
Yes.
John is giving out the job. You
Yeah, I think you need to speak to John. Yeah. Okay, so we have 2 more questions and we have time, so I'll try quickly because they're interesting. So there is a question about primary care, which I think is interesting. Happy that you mentioned pursuit of UHC and pandemic preparedness are not parallel functions. That was the beginning. My question is, could primary healthcare strengthening, as articulated in the call of Astana Declaration, be an anchor for the always-on approach? I think for you.
Well, I think it could be, but we have to think about what innovations actually reach the populations at risk. What has been remarkable is the ability for countries, and I look at India, for example, which didn't have really any kind of an adult vaccination program, yet they rolled out COVID vaccinations right throughout the country very quickly after facing a disastrous Delta wave that might have killed 3 million people. And that was done by not relying on primary health care. It was really purposeful, built approaches, identifying people, using the national identity card, which is the close to the digital infrastructure to be able to enroll things. And even now, the Indian government sits on a massive amount of data, which has got every individual's vaccination and their outcome data. They should be releasing it, so it would create the kind of knowledge and understanding of how you actually roll these things out. And similarly, I think the success in China in terms of rolling things out at very large scale are lessons. So, but primary care, we always have to remember, it is the core of healthcare, but it has to be complemented with 21st century tools, which would involve outreach services. It would involve the kind of efforts, learning from the successful programs in childhood vaccinations, the EPI programs, the efforts on polio elimination that have relied on a combination of routine and outreach plus the use of mobile technologies. Putting that together in a sustained way, I think, would be the challenge. And I believe the way to start really would be to build some country successes that actually change that outlook. Both Tony Blair and Nairi Woods reminded us that politicians do pay attention to what their peers are doing, and in public health we've learned that very much. We've had a remarkable success in reducing HIV by changing the behavior of sex workers. So if we can, through peer interventions, so if we can change behavior of sex workers through peer interventions, we should be able to change the behavior of politicians.
Thank you for this. Thank you for this. We have an interesting question on IP that I think we might want to try to tackle. There's been a bit of talk on both transferring IP and developing it on the ground in the global south in terms of vaccine technology. Should vaccines and vaccine technology be bound by IP? And if so, will that not continue to hamper a global, always-on approach? Who would like? I think Lynda. Lynda looks like she wants to tackle.
And if you could tie that to sex workers, we could.
Okay, so I do not. I think IP is actually a little bit of a distraction in a lot of the discussion, and I don't think we all should get too caught up in it. But I'll tell you my opinion about it. So I think the IP, the platform IP that is owned, for instance, the mRNA IP or the LNP IP, I think I don't think that's where people aren't going to give that up, right? Moderna is not going to give up its IP. BioNTech's not going to give up its IP, just because that's like asking them to, give up their heart, right? So they're not going to do that. But I think the solution, as we look to the future, is really to empower the Global South to generate IP in the antigen, and then you have a platform, and when you bring those together, you co-develop a product. And so I think there really is much more of a sort of, instead of this being a sort of combative thing, I think it's really thinking about how can this be a shared venture and a shared endeavor where both parties are bringing something to the problem, solutions to the problem, and moving things forward. But I think we all got there was a large argument about IP that was not productive or helpful, and I don't think it's the reason there aren't vaccines in the Global South. I think there are many, many other things that are problems that need to be addressed.
I see nodding from other panelists, so that's good. I think we have time for another couple. There are lots of interesting questions. That's been a panel that induced questions. There is a question from in-person attendee, Rachel, who is here, so it's great. And question is, I wish to learn more about your point on normalizing data sharing. What data ownership individuals have, especially in developing countries, in the data sharing that you are seeing? How do we encourage data contribution in patients? I think that's not only in developing countries. I see the same here.
It's amazing. I live in Los Angeles, a developed country. And when you look during the pandemic, over 3 years, every single one of our policy decisions was made on data from a small Middle Eastern country of 6 million people.
Yeah.
We had no data ourselves at all. There was zero feedback loop between give something and see what happens. We didn't even look. We just relied on Israel. So a remarkable concept there. At the same time, in today's world, you look at what happened with South Africa, who their data basically made them to be shunned from the rest of the world. And so there needs to be something in the middle there. We can go into your health record, no offense, and I can do an algorithm that looks at all of your morbidities, all of your co-conditions, a vaccine or an illness you got, and what your response was. And then I could take the answer, not your data, just the answer, and put it into a database. And so a database of those answers can give tremendous insight for that next patient so we can actually do the right thing. It took us a long time to figure out who was at risk. It took us a long time to figure out the behavior of this freaking virus. All of those, if we were able to actually have access to data, we could have done it almost in real time. So we have to figure out ways to basically make it so that we can look at that data in that privacy protected way. And at the same time, the notion that there's the Mayo Clinic data set, that there's the Harvard data set, that we're striping data sets by hospital makes no sense. Data should be striped by country and by globe. And we have to figure out a way to use that data, not to actually discriminate based on that data or harm anybody based on that data, but to use that data for public good. That data is what's going to enable us to survive pandemic Y, pandemic Z, and at the same time to live better with the medical conditions that we all have today.
Okay, so
Can I answer?
Please.
Just follow up? I think one of the really interesting and sort of paradigm shifting things about having this sort of data is around real world evidence, pharmacovigilance, and trying to actually, and using effectiveness data. And I think there is a paradigm in vaccine development where we could, really have our safety database, we could have some proof of concept, but then we actually roll things out and then we use the data, if we had it, to actually get effectiveness data afterwards. And so we would be able to license things in a very different way. And this would totally change the dollar amount that it takes to bring a vaccine to market. So I'm totally with David on his data.
It's the first time we agree. This is very exciting.
Right, so maybe you'll be co-chairs. Okay, so would you like to add something? We have 2 minutes and 17 seconds.
Sure. Just 30 seconds of disagreement on, use of administrative data to assess efficacy questions. I think in the pandemic we had no choice except to rely on places like Israel and Scotland and others. But we know from historic experience that large-scale, simple randomized trials that are set up and actually can use the health system to randomize would be there's no other standard for those. So we should remember that the randomized evidence is difficult. We have to think about how we reduce the regulatory barriers and completion of thousands of pages of forms to get a simple trial done. In contrast to deciding, as you said, patients decided to take the vaccine even if they were pregnant as an off-label. We have to think about how to build randomized trial structures that are actually feasible, and that's going the exact opposite way of the European Union directives and everything else, trying to make them simple and scalable and very large scale.
So this is great. There was, in fact, a question on clinical trials, but I think you already touched on this, so it's good. Now, apart from this great country that had all the data for US, that's Israel, there is, of course, another small country nearby called Scotland, and I see Aziz here, who used the data for whole Scotland to inform on many issues in great ways, so I need to say that's my job.
I said Scotland.
Yeah, you did. Aziz, hand up. Aziz, here he is. That's great. So we would like to continue in that line on the program as we progress. Now, I have in 27 seconds to tell you that I would like to thank fantastic panelists, you would agree, who were absolutely great. I would